Good afternoon, everyone. Greetings from Tata Memorial Center, Mumbai. I'm Dr. Santosh Menon, Department of Pathology from TMH. I thank Oncology Club and Dr. Kamal for having invited me here to deliver my lecture on pathology and molecular profiling of prostate cancer. As you all know, prostate cancer is an important entity, and with increasing longevity, the number and incidence of prostate cancer is going to increase. So, this is a short presentation on pathology. Some ethical disclaimer, this presentation has some images, cartoons, and smileys from the internet, which are solely used for the purpose of introducing an element of interest in this educational forum. Some data and graphs have been used from appropriate articles and have been referenced. There are certain images which are used for humor but are in no way disrespectful to the patients. There is no breach of confidentiality of patients in this presentation. So, a typical case scenario for prostate cancer would be an elderly patient who walks in with presenting symptoms of lower urinary tract symptoms. On evaluation, the urologist may find that the datal rectal examination shows a hard irregular prostate, and this would trigger off in general a PSA test for this patient who presents with LUTS and suspicious DRE findings. And if the PSA is more than 4 nanogram per ml, the usual idea is the procedure would be to do a prostate biopsy for this patient. So basically, the diagnosis of prostate cancer is by digital rectal examination, a serum PSA level, and if required, a biopsy. The issue with digital rectal examination and serum PSA is that many of the prostate cancers would be missed if only these tests individually or combined are used. So if you look at this data, 18% would have been missed if only PSA is done, and about 45% to 50% would be missed if only a DRE examination is used to diagnose prostate biopsy. Hence, there is a need for prostate biopsy in these patients. The basic understanding about prostate cancer is it is a multifocal disease. So the prostate, different parts of the prostate may develop different grades of the tumor. There may be some high grade pin lesions at separate foci. So in general, the understanding is that prostate cancer is a multifocal disease, and that is the very reason that you have to take multiple random biopsies or a template biopsies, systematic biopsies from prostate from different regions of the prostate, because different regions may harbor different grades of the prostate, and based on the grades, you have to take management decisions. So this is how we receive prostate core biopsies in 12 different containers, which are labeled according to the sites from where they are taken. And under the microscope, we diagnose prostate cancer when we see small infiltrative glands between the normal looking glands of the prostate. That's when we start thinking that this is prostate cancer. The classical features on pathology are small rigid glands, mucinous fibroplasia, a very peculiar stromal reaction, very prominent nucleoli within the nucleus of the prostate cancer cells, and the presence of perineural invasion. So these are the pathological features which we look for to diagnose prostate cancer. And sometimes we resort to absence of basal markers P63 and high molecular weight cytokeratin. In the malignant foci, these are absent as compared to the normal foci where it present, and the positivity for amacar, which is a fatty acyl enzyme positivity in the malignant glands. Now coming to Gleason grading, which is extremely important in prostate grading, it was started in 1966-67 by Sir Donald Gleason based on the pattern of tumor arrangement. He made some diagrams with astute observations of how the glands, as and more they become malignant, they sort of become single, and they become fused. The glands become fused, and they finally become single cell infiltrative pattern. And based on a combination of these patterns, he devised a Gleason grading system. So is it really important for the clinician, you being a urologist, is it really important for you to make decision? Is the pathologist report of any value? Does it convey something to you, or is it just a score which is given? Uh, I think Gleason grading, even after 50 years of its induction, is still one of the most powerful prognosticators in planning the management of the patient. It influences the treatment planning. It helps in predicting the pathological stage, extraprostatic extension, lymph node metastasis, seminal vesicle invasion, and the biochemical failure. So, a needle biopsy Gleason score helps you in predicting all these factors on a radical prostatectomy, or even if the patient is taken for other forms of treatment. If you look at NCCN guidelines, the stratification of prostate cancer patient extends from very low to very high groups, and in each of these groups, grading is an integral part of risk stratification of the patients, from very low to very high risk. The therapeutic options, I'm not going into details. You are all urologists, so you would know that surgical options are there. Radiation, hormone therapy form the main pillars of management of prostate cancer. But as more and more early prostate cancers are being picked up, active surveillance is also becoming an option. And in the coming years, you would see more and more patients being put on active surveillance. In 2005, the 1966 guidelines of Gleason grading were modified by the International Society of Urological Pathology, and they said that the fused and cribriform gland pattern should be placed in pattern 4, which was earlier in the original Gleason pattern placed in a pattern 3. They found that when the glands start fusing, the chances of propensity of the tumors to invade the surrounding structures as well as throwing distant metastasis increase, and that's why they should be put at a higher grade in pattern. So just as an example, this is to show that if a core biopsy contains a tumor of pattern 3, 60%, a pattern 4, 25%, and pattern 5, 15%, the original Gleason would have scored this as a grade 3, pattern 3 plus pattern 4 and a Gleason score of 7. That's because the original Gleason said that the commonest pattern and the second commonest pattern needs to be added up. Whereas in the ISUP 2005 modified Gleason scoring, what it is said is the commonest pattern and the highest pattern, even if the highest pattern is very, very minuscule in the core, it should form a part of the Gleason scoring system. So, according to the modified Gleason, the same core in current era would be put up as 3 plus 5, and the score would be Gleason score 8. Now, Gleason score 8 is really a high grade cancer. Uh, the if you look back at the original Gleason system, there were problems with it. There were probable scores of 1 plus 1 2, 1 plus 2 3, or based on different patterns of the glands. Adding up those patterns would give a several combinations and permutations of this scoring system. And in actual practice, what is seen is that you will never find a score of 2 to 5 being given on a core biopsy. So, as far as urologist understanding is concerned, you should never accept a report from a pathologist which says that the Gleason score is 2 to 5. The minimum score which can be given on a core biopsy is a Gleason score of 6, as 3 plus 3 is equal to 6, and 3 is the minimum pattern which can be picked up on a core biopsy. Another thought process which has come in very recent times is that 6, although it is in a spectrum of scale from 2 to 10, 6 it sits in the middle of the spectrum. In actuality and practicality of treatment of prostate cancer, a score of 6 is the minimum cancer which can be diagnosed by the pathologist, and at 6 is the minimum Gleason score which, as a urologist, you would be treating. So, if you tell a patient that the score extends from 2 to 10, and he comes to know that he has a Gleason score of 6, he would probably think that he's somewhere in the middle of the spectrum. And he would say that probably he needs an immediate treatment. But in actuality and practicality, it's the smallest cancer or the lowest grade of the cancer which can be diagnosed. And so these patients are candidates or can may be candidates for active surveillance without immediate treatment. And that has to be conveyed to the patient. There are certain other observations in recent years. It has been found after looking at 14,000 prostatectomies from several centers in the US that true Gleason score 6 or less does not have any potential to metastasis to the lymph nodes. And so the basic understanding is that the Gleason score 6 cancer is almost has got a nil metastatic potential. And the corollary to this is the Gleason pattern 4 is the crossroads for metastatic potential. So a patient who has score 7 is probably a patient who can develop a metastasis in the follow-up of the patient. So that's the basic understanding. So these understanding that 6 is the minimum cancer and 6 is a cancer which does not go to the nodes, does not metastasize, has led to certain modifications, and there was a need to develop new grading system to better align and prognosticate patient. And this new understanding in 2014, the International Society of Urological Pathology had a consensus conference in Chicago, and they came up with a new system which was validated in more than 20,000 patients across several centers in the US. And this is the current grading system which we use. It is nothing but a modification of the old Gleason system, in that the lowest Gleason score of 6 is now redesignated or rechristened as grade group 1. it has been understanding over the years that a 3 plus 4 7 is different from a 4 plus 3 7. The prognostication and the outcome of a patient whose score is 4 plus 3 7 on a core would be different from a patient who's would be worse compared to a 3 plus 4 7. So this made them split into two groups of grade group 2 and grade group 3. And if you look at grade group 4, it consists of all Gleason score, which have a combination to reach a score of 8. And grade group 5 includes all Gleason score of 9 and 10. So the idea of splitting was this: why were these groups made? What are these groups? Are these really relevant? They are relevant as they are prognostic grade groups. What we mean by grade group, these are prognostic grade groups, and they prognosticate the patients based on the Gleason scoring. So, like I said, the 7 has been split into two grade groups, grade group 2 and grade group 3, based on their prognostication. So, these have been well charted out on Kaplan Meier curves for biochemical recurrence. These grade groups have different outcomes when you look at biochemical recurrence free survival and recurrence progression free survival are different for all these groups. What do you do when you get the cores in different cores? You have cores which are separately sent in different containers. The idea is that most of the urologists would take the core with the highest Gleason score for taking decisions on management. This is just an example. These are core biopsies on pathology slides, and this is a patient who has had a 12 core biopsy. There are different Gleason scores on different cores of this slide. But if you look at this score, this has got the maximum highest Gleason score of 3 plus 5 8, and the patient would be managed based on this score rather than the average score of all the cores. Another example to show again similar 12 cores of a patient in which most of the cores have a Gleason score of 3 plus 3 6, but then there are a couple of cores in which there is a 4 plus 4 pattern and the Gleason score is 8, and the patient would accordingly be placed in grade group 4 and managed as per the highest score of the Gleason. So this is more beneficial. In this, the lowest group is 1 as opposed to current practice of Gleason score 6. So you can tell the patient that you are at the lowest end of the spectrum. So the Gleason score of the patient's pathologist prostate biopsy is 6. You can tell him that you are at the lower end of spectrum. The core involves, if there is tumor which is involving only two cores, the patient probably goes in for active surveillance, and it's easier to explain to the patients based on this new Gleason grading system. These are a couple of pictures to show that as long as we see very well-defined tumorous glands, we place them in pattern 3, and the Gleason score would be 6 in such cases. When the glands start fusing and then there's single cell pattern, then the scoring would be 4 plus 5 9, and the patient would be at the highest end of the spectrum. Uh, Another point I want to raise here is that when you give a Gleason score of 3 plus 4 7, it is imperative that the pathologist puts at how much percentage of pattern 4 is there. Because as the percentage of pattern 4 increases, the chances that the patient harbors a significant amount of pattern 4 is more in the prostate, and then the chances of metastasis and biochemical recurrence-free survival being less is more in these patients. So the percentage of pattern 4 is also important when reporting pathology codes. So when should you question your pathologist? That as a clinician, when you have a score of 6 versus score 7, you have to be absolutely sure that your pathologist is not making a mistake here, because score 6 patients would would be likely candidates to go into active surveillance, whereas a score 7 patient would probably need some kind of a therapy. And at the lower end of spectrum, the percentage of tumor and the pattern 4 percentage of pattern 4 does matter. So you should ask your pathologist whether he can really tell how much percentage of pattern 4 is there and how much tumor percentage is there. And in a metastatic setup, we definitely now know that a Gleason score 6 does not have a malignant potential to spread outside the prostate. So if you know that your patient is metastatic already and your pathologist has reported a Gleason 6, you should question your pathologist. So this is just a model prostate biopsy report in which you give the type of the prostate adenocarcinoma, the Gleason score, the grade grouping. You have to tell the number of involved cores, the percentage of tumor which is involving the core. The percentage of pattern 4 also helps you in deciding management in certain patients. And if the core biopsy shows some tumor which is extending into the adipose tissue within outside the core, the pathologist can definitely put in the report and should put in the report that there is extra prostatic extension. When it comes to radical prostatectomy, we are seeing more and more radical prostatectomies. in recent years, and the pathologist's main role is to sample the tumor here, assess the margins exactly, because post-operative radiotherapy is based on margin assessment of a radical prostatectomy, and obviously he needs to give you the staging information whether the tumor has gone beyond the confines of the prostate, or whether it has gone into the seminal vesicles. All this assessment of a radical prostatectomy helps in deciding adjuvant therapy, especially adjuvant radiotherapy, and basically the pathologist has only one chance to adequately examine the specimen. So this is basically a picture to show what the pathologist's role is, whether to say it is a T2 or a confined prostate confined tumor, or whether the tumor has extended beyond the confines of the prostate in a radical prostatectomy. So what we do here is, this is a cartoon to show how prostatectomy is grossed. The prostate is entirely embedded. It is cut through on several parallel planes, and it is completely embedded. And we examine each and every section of the prostate to look how the tumor is, what is the Gleason score, and how close are the margins, what is the it involving the margins, is there extra prostatic extension, is the seminal vesicle involved. So these is the important parameters which we want to report on a prostatectomy specimen. So this is just another cartoon to show what I just alluded to, whether the tumor is confined totally to the prostate, or the tumor is extending into extra prostatic, or it is extending beyond the prostate and involving the margins. Briefly about the molecular pathology of prostate cancer, which is of clinical relevance. I am not going to go into the details of molecular genetics of prostate, how it is formed, what are the main translocations. I would just briefly mention certain molecular things which are coming up, or which are already in practice in several Western countries, which help in managing these patients. So when you have an early prostate cancer patient, there are certain tests which are available in the market, called the Prolaris, the Decipher test, and the GPS oncotype testing, which are based on gene signatures. So they have different genes which act on cell cycles, proliferative markers. So based on those gene signatures, they can tell you whether the early prostate cancer, say a Gleason score of 6, whether it's going to remain, is it aggressive, or is it a very benign kind of a outcome in these patients. So based on these three type of tests, early prostate cancer can help in deciding management of the patient. Coming to advanced prostate cancer genetics, we can see that we have to remember the 5, 10, and 20 rule. 5% of them have microsatellite alterations, and they are candidates for immunotherapy, whereas 10 to 20% have either germline or germline and somatic BRCA mutations in prostate cancer, which are amenable to PARP inhibitor therapy. I'll just come to them very, very briefly and very shortly. So if you look at it, as and when the tumor cells are replicating, there are DNA damages, or when you're using therapies like some chemotherapy, there is DNA damage. A PARP, or inhibit PARP, would rectify this DNA damage and would cause the DNA to be repaired. What happens is, in the presence of PARP inhibitors, this DNA damage correction is prevented, because you are inhibiting the PARP. So PARP is an enzyme which causes these breaks to be repaired. But when you inhibit the PARP, the DNA damage persists. And then in BRCA mutated patients, what happens is, this BRCA is also unable to repair this double stranded DNA breaks, and the patient goes on to cell death. So especially in patients of BRCA mutation, or germline or somatic BRCA mutated patients, if you block the PARP inhibitors, what happens is, there is no mechanism which with the DNA damage it can be prevented in this, and the patient and the tumor cell goes on to cell death. So that's the fundamental idea behind PARP inhibition in BRCA deficient patients. It is already well known that BRCA1/2 mutated patients have more aggressive prostate cancer phenotype, with a higher incidence of nodal metastasis and distant metastasis. And it is in these patients of BRCA1/2 mutations, and several other of the same HRD combination pathway, where you can target using PARP inhibitors like olaparib. Coming to another one, which is the microsatellites. So microsatellites are nothing but short DNA sequences which are repeated in different variants among different individuals. And whenever the DNA divides, there are certain mistakes which are repaired by this MMR proteins, or microsatellite proteins. What happens is that If the patient has a mutation of MMR proteins, this DNA damage is not repaired, and then the patient develops a condition called microsatellite instability. So, in microsatellite instability, there will be several genetic mutations which keep on accumulating in the tumor cells, the leading to formation of something which is called as neoantigens. So, whenever you have a lot of mutations in DNA, they get translated into proteins, and these are neoantigens, and these new antigens can be recognized by the tumor cells, by the T cells of the patient, and the immunity of the patient can act there. But in general, the T cells are prevented by acting on tumor cells by the presence of this combination of PDL and PD1 and PDL1 interaction between the tumor cell and the T cell. So once you introduce a PDL1 inhibitor or a PD1 inhibitor, this inhibitory energy of the T cell is circumvented, and then the T cell or the host immunity is able to act on the on the tumor cells. And that is very very important to understand that when you give a PDL1 inhibitor, this kind of inhibitory effect of the tumor on the T cell is dysregulated, and then the T cell can act on the neoantigen expressing tumor cells to treat the thing. Another important thing which has come up in recent is the enzalutamide and abiraterone therapy, which are ARSI inhibitors or androgen receptor signaling pathway inhibitors. But if the patient harbors a mutation called androgen receptor variant 7 or ARV7 mutated tumor cells in the patient, then they are resistant to this therapy by enzalutamide and abiraterone. So in certain cases of metastatic castration sensitive prostate cancer, as well as metastatic castration resistant prostate cancer, where you are planning to give these therapies of enzalutamide and abiraterone, it is a good idea to work up the patient beforehand for the presence of ARV mutation. If they are harboring these mutations, then they would be resistant to therapy by this with this mutation. These are just pictures taken from the original paper from NEJM, which can clearly show you that ARV7 negative patients would behave poorly when you give them therapy with enzalutamide and abiraterone. Again, to show that ARV negative V7 negative patients can be given enzalutamide and abiraterone, whereas ARV7 positive variant of prostate cancer would be preferred to give docetaxel in these patients. Uh, Another short thing about the liquid biopsy. So you can take the blood of the patient to look at the circulating tumor cells and circulating DNA in these patients to treat them. And in general, it is understood that there is a lot of prognostic effect of circulating tumor DNA fraction in metastatic castration-resistant prostate cancer. So in metastatic castration-resistant, there are a battery of huge armamentarium drugs now available. Now, which of them are going to be effective? How effective them are they going to be? Can be easily understood by the number of the copy numbers of circulating DNA fraction in the blood. So that is important. Those tests can be done, and they can be used to tailor the treatment and management. So in a nutshell, when it comes to molecular pathology and treatment of prostate cancer, what are the things that you as a clinician should be looking forward to are is in a young patient less than 50 with family history of prostate ovarian breast cancer, you should be ordering the test of BRCA1 and BRCA2 in these patients. If they are found to harbor these mutations, they would become candidates for olaparib therapy or PARP inhibitor therapy. You should also order for MSI and MMR testing in metastatic CRPCs, because these patients would then be amenable to PDL1 therapy, inhibitor therapy, and that's also upcoming in the field of prostate cancer. If you have to decide between taxane and enzalutamide abiraterone therapy, it's a good idea to get the patient tested for ARV7 variant, because the patient harboring would not be have an effective outcome with ARSIs, and CT and CF studies on blood would help you in tailoring the management. I would like to end here by acknowledging my colleagues, my residents, and my technical staff. Thank you very much for your patient listening.